Preoperative care. Surgery is the art and science of treating diseases, injuries, and deformities by operation and instrumentation. The surgical experience involves an open and dynamic interaction among the patient, surgeon, anesthesia care provider, and nurse. Diagnosis: determination of the presence and/or extent of pathology with lymph node biopsy, bronchoscopy. For cure: elimination or repair of pathology, like removal of a ruptured appendix, benign ovarian cyst. Palliation: alleviation of symptoms without a cure, like cutting a nerve root, rhizotomy to remove symptoms of pain, creating a colostomy to bypass an inoperable bowel obstruction. Prevention: examples include removal of a mole before it becomes malignant, or removal of the colon in a patient with familial polyposis to prevent cancer. Exploration: surgical examination to determine the nature or extent of the disease, like a laparotomy. Cosmetic improvement: examples include repairing a burn scar or breast reconstruction after a mastectomy. Nursing assessment goals: the role for pre-op: have knowledge of the nature of the disorder requiring the surgery. Identify the individual patient's response to the stress of surgery. Assess the results of appropriate preoperative diagnostic tests. Provide a baseline by identifying potential risks and complications. The nurse caring for the patient preoperatively is likely to be different from the nurse in the operating room, post-anesthesia care unit, surgical intensive care unit, or surgical unit. The communication and documentation of important preoperative assessment findings are essential to the continuity of care. Patient interview: check documented information prior to the interview. Occurs in advance or on day of surgery, and the purpose is to obtain health information, determine the expectations, assess emotional state and readiness, and the interview also provides the patient and caregiver an opportunity to ask questions about surgery, anesthesia, and postoperative care. Often patients will ask about their routine medications such as insulin, warfarin, cardiac medications, or if they will experience pain. The overall goal is to identify the risk factors, plan care to ensure patient safety, and establish that baseline. Identify medications and herbs taken that may affect surgical outcome. Identify, document, and communicate results of laboratory diagnostic tests. Identify cultural and ethnic factors that may affect surgical experience. Determine receipt of adequate information from the surgeon to sign the informed consent, and determine if the informed consent and that informed consent is signed and witnessed. Nursing assessment: most people are anxious when facing surgery because of the unknown, and this is normal and is an inherent survival mechanism. However, if the anxiety level is high, cognition, decision-making, and coping abilities are diminished. Anxiety may be a result of past experiences or the vicarious experiences provided by friends' stories and the media. You, the nurse, can decrease some anxiety for the patient by providing information about what can be expected. Now, this is often done through classes or through the use of educational CDs before the day of surgery. Anxiety may arise from conflict with interventions like blood transfusions and religious cultural beliefs. Identify beliefs and discuss with surgeon and operative staff. The surgeon should be informed if the patient requires any additional information or if anxiety seems excessive. Surgery is a stressful event even when the procedure is considered relatively minor. Psychologic and physiologic reactions to the surgical procedure and anesthesia may elicit the stress response, elevated blood pressure, and elevated heart rate. Because the patient may be admitted directly into a preoperative area from the community or home, the nurse must be skilled in assessing vital psychologic factors in a very short time. You should notify the physician if the patient has a strong fear of death, which may prompt postponement. For fear of pain, you should stress that the patient should ask for medications following surgery when pain is present, and that taking these medications will not contribute to an addiction. Instruct the patient on the use of some form of pain intensity scale, like the 0 to 10, otherwise known as the 10 scale, or the FACES scale, and to request pain medication before the pain becomes severe. Fears include disruption of life functioning, range from a fear of permanent disability to temporary loss, include family and financial concerns, consultations as needed, and hope may be the strongest positive coping mechanism. Never deny or minimize, and assess and support. Some surgeries are hopefully anticipated. These can be the surgeries that repair plastic surgery for burn scars, or rebuild like a total joint replacement to minimize pain and improve function, or save and extend a life like repair of an aneurysm and organ transplant. Nursing assessment. Now you will need to determine if the patient understands the reason for surgery. For example, the patient scheduled for a total knee replacement may indicate that increasing pain and mobility are the reasons for the surgery. For a menstrual history, you should ask the date of the last menstrual period and the number of pregnancies. Questions regarding reproductive function may be embarrassing for a teenager in the presence of parents or guardians, so you may elect to ask these questions with parents or guardians out of the room. With regard to reactions to anesthesia, the genetic predisposition for the condition known as malignant hyperthermia is now well documented, and measures can be taken to minimize complications associated with this condition. Review the history if any family members died in surgery, could cause unusually high anxiety level, or a family history of problems such as malignant hyperthermia. Nursing assessment. In many ambulatory care centers, patients are asked to bring their medications with them when reporting for surgery. To facilitate accurate assessment and documentation of both the name and dosage of the current medications. In addition, assess and evaluate the patient's compliance with the Medicare regimen to identify other concerns. Drugs and herbal supplements may interact with anesthetics. The interaction of the patient's current medications and anesthetics can increase or decrease the desired physiological effect. It is also important to consider the effects of opioids and prescribed medications for chronic health conditions like heart disease, hypertension, depression, epilepsy, diabetes mellitus. For example, tranquilizers may potentiate the effects of opioids and barbiturates, which are agents that can be used for anesthesia. You should ask specifically about the use of herbs and dietary supplements because their use is so prevalent. Many patients do not think to include herbal supplements in their list of medications. They believe that herbal supplements are natural and therefore do not pose a surgical risk. Under recreational drugs, the substances most likely to be abused include tobacco, alcohol, opioids, marijuana, cocaine, and amphetamines. Ask questions in a frank manner about the use of these substances. You should stress that recreational drug use may affect the type and amount of anesthesia that will be needed. When patients become aware of the potential interaction of these substances with anesthetics, most patients will respond honestly about using them. Nursing assessment. You must question the patient about drug intolerance and drug allergies. Drug intolerance usually results in side effects that are uncomfortable or unpleasant for the patient, but not life-threatening. These effects can include nausea, constipation, diarrhea, idiosyncratic, which is opposite than expected, type of reactions. A true drug allergy produces hives and/or anaphylactic reaction causing cardiopulmonary compromise, hypotension, tachycardia, bronchospasm. You should inquire about non-drug allergies, specifically food and environmental, like latex, pollen, animal allergies. The patient with a history of any allergic reaction has a greater potential for demonstrating hypersensitivity reactions to drugs administered during anesthesia. Risk factors for latex allergy include long-term multiple exposures to latex products, such as those experienced by healthcare and rubber industry workers. Additional risk factors include a history of hay fever, asthma, and allergies to certain foods. When a patient is allergic to latex, special non-latex materials are used during surgical procedures, and the staff will need to know about the allergy in advance to obtain appropriate non-latex material and have them available on the surgical date. Prevention of allergic reaction, either contact dermatitis or anaphylaxis during surgery, is an important action. Nursing assessment. The last component of the patient history is the body systems review. Ask specific questions to confirm the presence or absence of any diseases. Past medical problems can alert you to areas that should be more closely examined in the preoperative physical examination. In reviewing the cardiovascular system, you may find a history of cardiac problems, including hypertension, angina, dysrhythmias, heart failure, and/or myocardial infarction. You should inquire about the patient's current treatment for the cardiovascular condition, like their medications, and the level of maintenance and functioning. Ask the patient if he or she is being followed by a cardiologist. If the patient has had a recent myocardial infarction, a pacemaker, or an implanted cardioverter defibrillator, or if a cardiologist was consulted before surgery. Postoperative venous thromboembolism is a condition that includes deep vein thrombosis and pulmonary embolism and is a concern for any surgical patient. Patients at high risk for venous thromboembolism include those with a history of previous thrombosis, blood clotting disorder, cancer, varicosities, obesity, smoking, heart failure, or chronic obstructive pulmonary disease. Nursing assessment respiratory. The respiratory system, smokers should be encouraged to quit 6 weeks before a procedure. Decreases the risk of their complications. The greater years and number of packs equals the greater risk. Conditions likely to influence or compromise respiratory function are such as sleep apnea, obesity, and spinal, chest, and airway deformities should also be noted and reported. Depending on the patient's history and physical examination, baseline pulmonary function tests and arterial blood gases may be ordered preoperatively. Nursing assessment, nervous system. Alterations in the patient's hearing and vision may affect responses and ability to follow directions throughout the perioperative assessment and evaluation. The patient's ability to pay attention, concentrate, and respond appropriately in the preoperative phase must be documented to establish an accurate baseline for postoperative comparison. Nursing assessment, genitourinary. Male patients may have physical alterations such as an enlarged prostate, which can interfere with the insertion of a urinary catheter during surgery or can impair voiding in the postoperative period. For women of childbearing age, you need to determine if they are pregnant or think they could be pregnant. The surgeon must be informed immediately if the patient states that she might be pregnant, because maternal and subsequent fetal exposure to anesthetics should be avoided during the first trimester. Nursing assessment, hepatic system. The patient with hepatic dysfunction may have increased perioperative risk for clotting abnormalities and adverse responses to medications. You should consider the presence of liver disease if the history includes jaundice, hepatitis, alcohol abuse, or obesity. Nursing assessment, integumentary system. Look for a history of pressure ulcers, extra padding during procedure, and it affects their postoperative healing. Nursing assessment, musculoskeletal. Bring mobility aids to surgery. Report problems affecting neck or lumbar spine to advanced care practitioner. Can affect airway management and anesthesia delivery. Nursing assessment, endocrine. Advanced care practitioners vary the usual insulin dose based on the patient's current status and history of glucose control. Regardless of the preoperative insulin orders, the patient's glucose levels will be assessed periodically and managed if necessary with regular, short-acting, rapid-onset insulin. Patients with diabetes mellitus is clarified with the physician regarding insulin dose. Patients with diabetes mellitus, especially at risk for ketosis, cardiovascular alterations, delayed wound healing, infection. Patients with thyroid dysfunction need to verify with the practitioner about giving thyroid medication. Patients with Addison's disease, the stress of surgery may require increased dose of corticosteroids. Nursing assessment, immune system. Corticosteroids used in immunosuppressive doses may be tapered before surgery. If the patient has an acute infection, acute upper respiratory tract, acute sinusitis, or influenza, elective surgery is frequently canceled. Patients with active chronic infections such as hepatitis B or C, acquired immunodeficiency syndrome, and tuberculosis may have surgery if indicated. However, when preparing the patient for surgery, remember that infection control precautions are taken for the protection of the patient as well as the staff. Nursing assessment, fluid and electrolytes. Although a preoperative fluid balance history should be completed for all patients, it is especially critical for the older adult because reduced adaptive capacity leaves a narrow margin of safety between overhydration and underhydration. Anticholinergic medications decrease oral secretions, so the patient is taught that a dry mouth is an expected side effect. Now, chronic use of garlic may predispose to intraoperative and postoperative bleeding. The use of a sedative the previous night, an occasional acetaminophen use, and a distant history of cocaine use will not usually affect the surgical outcome. The low potassium level may increase the risk for inoperative complications such as dysrhythmias. Slightly elevated blood pressure is common before surgery because of patient anxiety. Nursing assessment, nutritional status. Notifying the team that a patient is morbidly obese with a body mass index greater than 40 kilograms allows time to obtain special equipment needed for the care of this patient, like longer instruments for abdominal surgery. If the nutritional problem is severe, the surgery may be postponed. Nutritional deficiencies of protein and vitamins A, C, and B complex are particularly significant because these substances are essential for wound healing. Supplemental nutrition may be administered during the perioperative period to patients who are malnourished. The older adult is often at risk for malnutrition and fluid volume deficits. Nursing assessment and the exam. So documenting the relevant findings. For example, if the patient is taking an antiplatelet medication like aspirin, a coagulation profile may be ordered. If a patient is on diuretic therapy, a potassium level may need to be assessed. If a patient is of childbearing age, a pregnancy test should be ordered, or if a patient is taking medications for dysrhythmias, a preoperative ECG, electrocardiogram, will probably be performed. Listen to breath sounds. Abnormal breath sounds may indicate the presence of an acute respiratory infection or chronic lung disease that will affect the choice of anesthesia and/or proceeding with the scheduled surgery. Nursing management. Teaching may also decrease the development of complications, the length of hospitalization, and the recovery time following discharge. Preoperative teaching for these patients is generally done in the surgeon's office or the pre-admission surgical clinic and is reinforced on the day of surgery. Preoperative teaching should be several days before surgery. Observe and listen to determine amount of teaching for each session. Anxiety and fear can hinder learning. Give priority to patients' concerns. When providing preoperative teaching for a patient several days before surgery, you must provide a balance between telling so little that the patient is unprepared and explaining so much that the patient is overwhelmed. Nursing management. Preoperative teaching. With sensory information, patients want to know what they will see, hear, smell, and feel during surgery. For example, you may tell them that the OR will be cold, but they can ask for a warm blanket. The lights in the OR are very bright, or they will hear lots of sounds that are unfamiliar and may notice specific smells. Patients may not want a lot of specific details, but desire to know the general flow of what is going to happen. This information would include the patient's transfer to the holding area, for transfer to the OR, and waking up in the PACU. With procedural information, desired details are more specific. For example, this information would include that an IV line would be started while the patient is in the holding area, and the surgeon will mark the operative area with indelible marker to verify site and side. Preoperative teaching must be documented and reported to postoperative nurses. Nursing management pre-op teaching. And the patient should also receive accurate surgery-specific information. For example, a patient having a total knee joint replacement may have an immobilizer following surgery, or a patient with extensive neurosurgery may need to be told about waking up in the intensive care unit. Basic information before arrival, like the arrival time is usually 1 to 2 hours before the scheduled time of surgery to allow for completion of the preoperative assessment and paperwork. Information can also include the day of surgery events such as patient registration, parking, what to wear, what to bring, and the need to have a responsible adult present for transportation home after surgery. The time and place, fluid and food restrictions, need for an enema, need for a shower. Restriction of fluids and food is designed to minimize the potential risk of pulmonary aspiration and to decrease the risk of postoperative nausea and vomiting. The patient who has not followed the MPO instructions may have surgery delayed or canceled, so it is critical that the surgical patient understand and adhere to these restrictions. St. John's wort may prolong the effects of anesthetic agents and increase the time to awaken completely after surgery. Preoperative teaching, demonstration, and re-demonstration of deep breathing and coughing are needed on patients having abdominal surgery to prevent postoperative atelectasis. Incisional care and the importance of completing antibiotics are better discussed after surgery when the patient will be more likely to retain this information. The patient does not usually need information about medications that are used intraoperatively. The patient will be at risk for a fall after receiving the opioid, so the best nursing action is to have a patient use a bedpan or urinal. Having the patient get up either with assistance or independently increases the risk for a fall. The nurse should allow more time when doing preoperative teaching and preparation for older patients with sensory deficits. Preoperative insulin administration is individualized to the patient, and the current blood glucose will provide the most reliable information about insulin needs. It is not possible to predict whether the patient will require no insulin, a lower dose, or a higher dose without blood glucose monitoring. Nursing management consent. Legal preparation. All required forms are signed and in the chart. Informed consent, blood transfusions, advance directives, power of attorney. 3 conditions must be met for consent to be valid. First, information must include adequate disclosure of the diagnosis, the nature and purpose of the proposed treatment, the risks and consequences of the proposed treatment, the probability of a successful outcome, the availability, benefits, and risks of alternative treatments. Second, the patient must demonstrate clear understanding and comprehension of the information being provided before receiving sedating preoperative medication. Third, the recipient of care must give consent voluntarily. The patient must not be persuaded or coerced in any way by anyone to undergo the procedure. Medical emergency may override the need for consent. When immediate medical treatment is needed to preserve life or to prevent serious impairment to life, and the individual patient is incapable of giving consent, the next of kin may give consent. If reaching the next of kin is not possible, the physician may institute treatment without written consent. Legally appointed representative of a family may consent if the patient is minor, unconscious, mentally incompetent. Surgeon responsible for obtaining the consent, and the nurse may obtain and witness signature. Verify patient has understanding. Permission may be withdrawn at any time. The surgeon is responsible for explaining the surgery to the patient, and the nurse should wait until the surgeon has clarified the surgery before having the patient sign the consent form. The nurse should communicate directly with the surgeon about the consent form rather than asking other staff to pass on the message. It is not within the nurse's legal scope of practice to explain the surgical procedure. No preoperative medication should be administered until the patient signs the consent form. Nursing management day of surgery. Patients should not wear any cosmetics. Observation of skin color is important. Remove the nail polish for pulse oximeter. Valuables are returned to family member or locked up. Dentures, contact, prosthesis are removed. Identification and allergy bands are on the wrist. Void before surgery. Prevents involuntary elimination under anesthesia or during early postoperative recovery. The value belief pattern includes information about conflicts between a patient's values and proposed medical care. In the cognitive perceptual pattern, the nurse will ask questions about pain and sensory intactness. The sexuality reproductive pattern includes data about the impact of the surgery on the patient's sexuality. The coping stress tolerance pattern assessment will elicit information about how the patient feels about the surgery.